Welcome to the Caregiver Relief Podcast. I'm Diane Carbo, RN, your host today. This episode is sponsored by myvitalvault.net, your all-in-one life organizer for aging adults and caregivers. It's designed to help you securely store your essential legal, medical, and emergency information in one easy-to-access place. Because when a crisis hits, being prepared can make all the difference. Join our Caregiver Relief community, a warm, welcoming space where you can connect with other caregivers, ask questions, share stories, and find support from people who truly understand. Visit community.caregiverrelief.com to join now, because caregiving is one of the hardest and most meaningful things you'll ever do, and no one should have to do it alone. And if this episode speaks to you, please take a moment to like, share, or comment. Every click helps us reach more caregivers who need encouragement, resources, and hope. Today's episode is titled Hidden in Plain Sight: The Silent Epidemic of Substance Abuse in Older Adults. This is an issue that too often goes unrecognized but has devastating consequences for seniors, families, and caregivers. And I'm honored today to be joined by Dr. John Dyben, an accomplished researcher, counselor, and national speaker who currently serves as Chief of Research and Innovation for Hanley Foundation. With advanced training in psychology, family therapy, addiction counseling, and healthcare leadership, and even a doctoral practicum focused specifically on substance abuse in older adults, John brings a wealth of information and expertise to this urgent topic. Together, we'll uncover why this problem is so often missed and what signs caregivers should be watching for, and what solutions exist to help seniors find hope and recovery. John, thank you so much for taking time out of your busy day. This is such an important topic and one that's always overlooked.
Thank you so much for having me. I agree. Anytime we get to talk about this, it's so critical. So thank you for making this a topic today.
I'm an adult child of an alcoholic, and I see it so everywhere. So I really think that we needed to talk about this. Before we dive into the really nitty gritty, can you share what inspired you to focus on substance abuse in older adults?
So I started my career as a pastor in church ministry and went to seminary. And when I started, I thought I'm going to just be a theologian and be a kind of a heady thinking guy. And it was in my I was probably 19 years old, the very first time I was actually working with a group of kids and inner city kids. And I learned real quickly that they didn't care about my ability to discuss the finer parts of the metaphysics of morals.
Yeah.
I could listen to them, and that helped them. And so I said, you know what, I'm going to change my major. I changed to psychology. And even when I went to seminary, it was focused on counseling. And I said, I'm going to work with adolescents the rest of my life. I never want to work with anybody over the age of 30. And over the years, I worked for Boys Town. I did a lot of work with children and adolescents. But a little over 21 years ago, through relationships and different things, I came to Hanley Center. And Hanley Center is a facility in West Palm Beach. At the time, it was still part of Hazelden. And Hanley Center had three major programs at the time. We have many more now, but at the time, there was a men's program, a women's program, and there was an older adult program. And the older adult program was the only one in the entire country. In our nation's history and I thought, and I was working on the men's unit, and I said, I'm just going to keep working on the men's unit because I believed some myths that I think a lot of us in our culture, good people, loving, wonderful people, have believed. And one of the things that I thought is this idea of almost what's the point? Why in the world, if someone has gone all this way, they're 70 years old, 80 years old, 85 years old, why does it really matter if they have addiction? And I'm sorry to say that I think that's a common belief, and I had that. And I met the lady who had literally written the only book on the subject. She literally had bullied Hazelden into allowing her to develop this program. And I became friends with Carol Colleran. And Carol has since passed, but Carol saw the problem. What she said is she looked at this men's program and women's program, and every once in a while, you would get an older adult. And she said, and one of the two things would happen. Either they would look around and go, this isn't for me, and they would sit and they would be quiet and they would be the perfect patient. And so they'd get no attention and they do no work. Yes. And then after a certain amount of time, they would go. Or they would become dad or mom or grandpa or uncle or aunt to the group, and they'd take care of everybody else. And she said that she did her research and she realized older adults have different need from younger adults in treatment, and treatment's built for younger adults. And so she bullied her way, and anybody who knows or has ever met her and hears this go, yes, they know that she was said that older adults deserve it. And she became a mentor of mine, challenged every one of those false beliefs that I had about older adults that I didn't know that I was carrying. And that started me on a journey of working with that population, realizing how incredibly devastating addiction is in older adulthood. And it just gave me a passion for researching that and for making it known to people as much as we can.
God bless you for bringing this up, and God bless Carol, because I will tell you, I cannot tell you how many people, seniors, have avoided going to rehab for treatment because it was all young children or young kids or young adults, and they couldn't relate. And they're saying this, and you're right, they say it's not for me. And I am so excited that I can actually tell people about your program because it's so desperately needed, because we really do have this silent epidemic. And could you explain to my listeners why we call this issue a silent epidemic?
Absolutely. So there are estimates that somewhere around 5 million older adults in the United States today, and this is a rough estimate, but even if it's anywhere even near close, imagine that, meet criteria. If they walked in my office for an assessment, if they walked into you for a clinical for an assessment, they would meet criteria for a diagnosis of some kind of substance use disorder. Alcohol is still the number one. So you've got millions of people that what that means is that the quality of their life in the time where life is shortest, in the time where quality of life, quality of relationships, that there's this idea that we reach a certain age and our ability to fully engage life becomes less important or less valuable. And that's such a myth. It's such a lie. The reality is that my ability, and I think of both of my parents, they're approaching 90. They are still alive today, and their ability to fully engage in relationships with their children and their grandchildren and their great-grandchildren is so important. And there is this myth, there is this idea within our culture of what I call discount people. Because you see, the reality is I'm still a guy I'm living a very active life, and I'm working and I'm raising kids and I've got adult kids and I'm doing all these things. If I were to develop an addiction today, you'd know it. You would see it. You'd experience it. I wouldn't be showing up for work. I'd be getting DUIs. But if one of my parents was to develop an addiction today, they don't have work to show up for. They don't really need to travel all that much. And so our culture would not see it, because if we don't see it and experience it, we don't think it exists. And so these folks suffer often in silence, and there's millions of them.
And social isolation in seniors is rampant. And it's really sad because we don't have enough youth to take care of our seniors. It really is an epidemic. It's a cultural, societal problem that we need to address. I'm 72. I had a grandmother who lived into her late 90s. And when we grandkids got married and moved away, she got very lonely and she always hid her drinking. And we discovered it. She would buy a box of wine and hide it in her room. She was really an upscale drinker, let me tell you. Buy a box of wine and hide it in her room and drink it so nobody knew. And of course, when you go to visit, when you're from out of town, you find these things and you see the issues. And it just broke my heart because she never drank when she was younger. Just something, I guess she was trying to sedate herself. People will take it, use the excuse, I'm using it for sleep, when it's not a good sleeping medication at all.
Right.
So how widespread is substance abuse, and what are most commonly drugs or substances are most commonly used by seniors?
Alcohol is absolutely by far the most common drug that would cause a substance use disorder that's problematic in older adulthood. And one of the things that kind of exacerbates that is because I am an aging American, whether I like it or not. Hi, I'm John, and I'm an aging American, and that's the way all of us are. But as we age, and especially after we hit around 40, our bodies change. And one of the changes is the way we metabolize drugs, especially alcohol, changes. And one of the things that's really important is that we have a decrease in total body water. And so that's all the fluids in there that are really important for decreasing or for metabolizing alcohol. So what it basically means is a glass of wine that I had at 30 years old, if I am exactly the same height and weight at 60 years old, that same glass of wine in that same body, just 30, is going to raise my blood alcohol level faster and keep it raised for longer. And so one of the most famous things that we saw was, and I love her for her honesty, Ruth Bader Ginsburg, who is this brilliant, no matter what anybody thinks politically, she was brilliant lawyer. She was a Supreme Court justice. And there was an incident that occurred during the Obama, I think it was one of the State of the Union addresses. She fell asleep. Now, think about this, right? So this is a brilliant person. She knows the world is watching her, and she let herself fall asleep. They famously, everybody made a big deal of it. And they said, what happened? And she said, here's what happened. I'm going to tell you the truth. It is tradition that before the State of the Union, we have a spaghetti dinner. And one of the justices brought a super nice bottle of wine or two, and I had a glass, or she might have had two. It's not like they were having a kegger. But what she said is, this is the normal. I would normally drink this, and it would have no effect on me.
Yes.
But I have to be honest, even though I don't want to admit it, alcohol is having a greater effect on me than it ever has. That's tough to admit. None of us want to admit that our bodies are changing and such. Exactly. So what we see, number one, is alcohol is by far the number one. And we're talking, again, about 5 million. Estimates are about 5 million people would meet criteria for an alcohol use disorder, meaning that their use is starting to cause problems in their lives. Interestingly, cannabis, I'm sorry.
But no, go ahead. No, go ahead.
The number two, it's far behind, but the number two is actually cannabis.
Yes. As a nurse, we would go in some nursing homes or in assisted living. And one of the things, people that wanted drinks, the doctors would have to write a script for it, write an order for it. Okay. And it was called Spirits of Fermenti, and all it was whiskey. And I had patients eat well into their 90s that had a standing order that had to have it every day. And I'll never forget this one little lady, God bless her. She was so tiny and she looked malnourished and very wealthy. And I would give her her martini every day. And if I was late, Lord have mercy, there was hell to be paid. And it was challenging because I could see how it was impacting her, but people just accepted it, that it was okay for her to be off balance and have slurred speech for such a long period of time afterwards. So I see it all the time.
And this is why I love nurses, because even the problem, you describe it in the actual, what are the problem? If someone, sometimes people think that those of us that work in addiction, we think we moralize or think it's bad, it's a moral thing to drink, or we're exactly the opposite. If alcohol or any other drug does not cause problems in your life, I'm not going to make a point of it.
Exactly.
But when it's causing you to be, in that case, that patient is off balance, a risk of falling and hurting herself. Yeah. But more than anything, what I see is that it causes disconnect between older adults and the most important relationships in their lives. And I see it again and again. In fact, that's what brings most older adults to treatment. Very often, the intervention or the final thing that will bring an older adult to treatment is a grandchild saying, "Hey, grandma, grandpa, I love you. Every time I come over, I used to love our talks, and I can't talk to you anymore because you're that slurred speech. I know you're intoxicated, and I love you, and I want to have that relationship again, but we're disconnected." And it's so powerful.
Yes. Yeah. I worked in some upscale assisted livings, and I had a liquor store call me one time because one of my clients, now I have to tell you, in assisted living, you're on your own. You can do whatever you want. And if you want to go to the liquor store and it's safe for you to drive there and come back, I can't stop you. And they were calling me because this guy was buying so much booze every week, and they were having parties in his room. And the thing is, these guys, we had issues because arguments and fights started to occur. And it's that, I don't care if you drink, I care when it impacts other people or it impacts the personal safety of somebody else or yourself. And it was a challenge because we were limited to what we could do, and we had to go to the adult children who were like, "Oh my God, we didn't know Dad was this bad." Right. Whoa, oh, trust me. And he was going through his finances. That's huge.
And all of those things are those problems that go along. If those problems weren't there, we're not the drinking police. We don't have but we are healthcare providers, and our job is to help people have full health. And full health, I love the World Health Organization. In 1946, I'm pretty sure that's the right, someone's going to check me out. It might be 40. But prior to my birth, or the World Health Organization grappled with, how are we going to define the word healthy? How are we going to define that? And what they came up with is a simple definition, and I'm going to butcher it. I encourage people to look it up. It's so beautiful. But the definition is that health is not merely a state of not being in disease, but is physical, mental, and spiritual sense of wholeness. It is a sense of whole person wellness. And it's amazing that is still the World Health Organization's definition, but it's wild that it sounds very hippy dippy, but it was 1940s that they said health is more than just you're not having a disease.
That's beautiful. I love that definition.
It really is.
Yeah. Yeah. We have a problem with prescription medications in this country. How is that contributing addiction to this population as well?
Not only addiction, because if you look at opioids, and that's where there are two main categories of prescription drugs that we see as very problematic, that have very high addiction potential. Of course, that's opiates. And benzodiazepines are those things like Xanax. These are probably the most common that people are going to be familiar with. And those are both very highly addictive drugs. Opiates, people are very familiar with them, and they've been in the news for years because they've been the number one killer. Yeah. Even though they're the number one drug to cause death by overdose. It is arguable that that alcohol kills even more people, but a direct cause, opiates are a big part of that. And benzodiazepines are essentially, it's a central nervous system depression. It's a lot of just doctors will describe it as it's like alcohol in a pill form. So it's just as addictive. It's actually even more addictive. And you hit on something that's really important, that though alcohol, and when I started here, like I said, 21, almost 22 years ago, we would see people come in with just alcohol use disorder. And in fact, and of course, again, it wasn't even called that. It was alcohol abuse or alcohol dependence. Yes. We'd see people come addicted and alcohol was their drug. And there were a lot of them. Today, that is almost, it would be a unicorn. It would be so unusual to see someone just addicted to alcohol. What we see is alcohol plus, and the big one is those prescription drugs, right?
Yes.
And they have this synergistic effect where when you're combining one drug with another, especially when they are both mood altering, they have the addictive property, and the fact that you can get addicted, it just skyrockets. And years ago, Karen, there's a treatment center in Pennsylvania, they have a research arm. They did an interesting poll. They polled adult children who were responsible in some way for their parents' medical care. And one of the things they asked was, do you think it's a problem if mom or dad combine alcohol with their other prescription meds? And the vast majority said, no, it's no problem at all. So one of the things that we see is, though there are some guidelines over the past few years, guidelines have been getting better, but prescribers are still far more likely to prescribe an addictive medication like an opioid or a benzodiazepine that can increase the likelihood of addiction, much more likely to provide those drugs to my 87-year-old mom than they are to me. And the idea, I think, and this is where, and it's not because these doctors are evil but I think people don't realize, you were probably taught this. I was certainly taught this in my training. I was taught years and years ago, if you don't develop addiction by the age of 40, you'll never develop addiction. That was something that was a common belief.
Yes, but I knew that wasn't true because of my grandma, because of what I saw in my nursing career. Yes.
And thank God that you took that knowledge. And what we want people to know is that is now what we understand through a lot of the research, and it is not true.
Yes.
A person they can cross over into that addiction at any age. And so the precautions against addiction should be taken no matter what age a person is.
Now they're saying that doctors are trying not to prescribe benzodiazepines because they also give you a propensity to develop dementia. And the studies are there, they're very strong. And my son is a nurse anesthetist, and he has a ketamine clinic, and he just went back to school to become a psychiatric nurse practitioner. And his practice now is helping people. One of the things he's doing is to get off the benzodiazepines because it's really hard. But you know what? I have to tell you, I see it all the time where I work with people in emotional, physical pain all the time. And it always astonishes me how they'll call the doctor and say, my sister died. I need to cope. Can you give me some Ativan or Xanax?
Yes.
And the doctors willingly do it. And I just it just makes me sad because I know some people that are getting it have gone through treatment. They've been in recovery. They've been sober for decades. And this is their crutch now. And it's not good. It's just not good because it's just one step closer to breaking your sobriety, or it's a different form of breaking your sobriety.
And you're so right on, especially when it comes to issues of grief. One of the things that any type of When I think of alcohol, benzodiazepines, they are emotional anesthesia.
Yeah.
And what they do is there's a process of grief that's really hard. When we experience loss, there is a process that we go through that never makes it go away.
Yep.
We're changed forever.
Yeah.
But where we can, that wound can become a scar, a healthy part of us, or we can keep it just an open, festering wound that keeps making us sick. And what that does, if I am just using a benzodiazepine to not feel grief, I'm just pushing a pause button on that grief.
Yes.
And the other thing is that and this has been known for quite some time. The first study is probably 20 years old, but one of the things that research has shown us is that if somebody has an acute panic attack, a benzodiazepine is incredibly effective. But for chronic stress, including chronic anxiety, when you look at, and there are different studies that have repeated this, and they treat one group with psychotherapy only, one group with benzodiazepines only, and one group with psychotherapy and benzodiazepines. The happiest in the immediate is just benzodiazepines. I feel better. 12 months, most improved is psychotherapy with no benzodiazepines. And that word crutch is used a lot in a lot of different inappropriate ways, but man, I think you've nailed it on the head here. If my foot hurts, and so I say, I'm going to put myself in a wheelchair forever, what's going to happen? My muscles will atrophy. It'll actually become worse. And that's what happens with our ability to deal with distress when benzodiazepines are used chronically.
Exactly. Yeah. It's like, I envision it as I tell people your emotions, I take a punch bowl and I fill it with water, and then I put tennis table balls. So they're lightweight and they're little, and I put them on the top. And then I say, imagine, and I'll take and push them down, and they all keep finding a way to pop up. And I said, that's your emotions. And if you press them down,
I love that,
and try to suppress them, they're still going to pop up. So you need to learn to deal with it. And that makes sense to people when they see that actual demonstration. Oh, okay. And I think that sedating ourselves to feel numb or not healed or not to feel is a bad way of coping. And it's hard for people to allow themselves. It's like opening Pandora's box when you first realize that you're doing it. And it's really hard to allow, people hate to allow themselves to feel unpleasant emotions.
And you've got such an important key, because I want to be clear, this is not any anti-medicine or message. You're a nurse and a health professional, but medications can be life-saving, psychiatric medications. But the key is this: medicine should help us use the word cope. Cope, the word, that definition, it's one of my favorite words. It is struggling successfully. It's not struggling. It's struggling successfully. So if I'm on a medication that is decreasing my quality of life, decreasing my ability to fully connect to other people and connect to myself, then that's keeping me stuck. If the medications I'm on are helping me to provide enough structure to be able to cope, to struggle with things, then that's the proper use of medicine. And I think it's such an important point.
I agree. I love that. Struggle successfully.
Isn't that beautiful?
It's beautiful. And I'm going to use that term now because we all struggle through life. It's never easy peasy for anybody. And I lost my mother at a very early age. I was 17, and I lost my oldest son to suicide. And one of the things that I struggled with was grief. And I was always surprised at how people would say to me, they thought I should already be over it. Or they'd say, what are you doing for it? Have a pill. And I'm like, no, you don't get it. I had to learn, as I said, I'm an adult child, I'm an alcoholic. So I had a lot of dysfunctional habits. I don't eat, I don't drink, I don't do drugs because I was a nurse. I don't do drugs, but I didn't drink, not because of, for any reason that I didn't want the calories all the time. And I just didn't like the way, I don't like to be out of control. It's just people struggle in different ways, but I allow myself to have those awful feelings and they still exist. My son it's 14 years and my mom, it's 52 years. And I still struggle with feelings of sadness at times, but it's not overwhelming me. And I allow myself to feel it for a day or so, and then it's time to move on, and I do things, healthy things. I get out and interact with other people. I think one of the things that drugs do is, like you say, it keeps us from having human connection with others. When you withdraw, you're just in your own little cocoon, so to speak. And that's really hard to get out of, and it takes work. But with help, with therapy, and making yourself get out and be with people that you can interact with, I think is really important.
Absolutely. And that's why treating older adults, and thank you for sharing that, because I think it's so important for people to hear. For me, I don't care, for all of us. I need to hear it too, right? Yeah. We all need to be reminded, because you know what? There are terrible things that happen and pain is real and we can survive it.
Yes.
And you know what? There's no magic cure and there is no time. Oh my goodness. And people are so caring and they're loving and they mean well, but the expectation, and you know what? So many people will come to treatment and they'll say, I shouldn't feel, I don't want to talk about this thing that happened in my life because it happened 10 years, it happened 20 years ago, and I should be over it by now. Yeah. And it's not true. It
exactly
becomes part of us. But that's why it's so important. Having an older adult program is important for many reasons. They have different medical needs, different psychological needs, but that's social. We have a mentor of mine, Dr. David Powell, talked about the two general movements in life. And he talked about the second half of life being the movement from success to significance. And so we're in a different mindset. We're beginning to think about meaning rather than function. If I'm 26 and I'm thinking about function. How am I going to get a house and get a wife and get the kids and get the,
yeah.
But there's a point where we move to meaning becomes more important and more of our focus, and having community of people who can hear and share on that same level is critical for healing.
You know what? I love that you pointed that out, because everybody asks me, why are you still doing this at 72? Why are you reaching out and helping people? Why you should be retired, relaxing, enjoying. And it's not that I don't, but I do work a lot. It's an ism that I have. But you know what? I'm also trying to be significant in the world right now, that with caregivers are struggling, and there's so much pain and suffering out there in different ways, especially with the aging population. And I feel like this gives me a voice to help others. So I'm trying to make myself significant. So you just help me realize why I do what I do.
That is so beautiful. So you're a nurse, which means that nurses are unique. The nurses, you all are different people. I've never met a nurse that was not passionate about the work they did. Not one.
Yeah.
Even those that I've met them that were burnt out and are like, nurses go into nursing because they believe in something, but also because if you think about when you first went into nursing, there was probably some really practical stuff. I need to make a living and I want to be a professional and so it was like the tasks and the what. And it's so beautiful to hear you say that, because it still is work and you're still doing this work, but now it's more about the why. It's more about the meaning. And I think that
100%.
So beautifully.
It's no longer about the money. I'm not working overtime. I'm not trying to saving for a vacation or something. For me, I just want to make a difference in other people's lives. I just realized that as we're talking, because I beat myself up all the time and people get upset because I do so much of this that they're saying, you should be going on vacation. You should be doing this. How about let's go out for a drink or something? And they all know that I don't drink. And I'll have to tell you something funny. I had a friend who was recovering and I said to her, I don't drink. And she goes, aren't you worried people are going to think you're an alcoholic? I laughed and I said, that never even occurred to me. But if they did, that's their issue. It's not mine because I am what I am. And it's not that I don't like a nice drink once in a while. It's just, I don't need it. I don't have a care for it. And the other thing is, I don't like the way it makes me feel. And I don't want to be in a situation where I'm not in control. And that's my issue. That's a whole nother issue. But can you tell me what makes diagnosing substance abuse in seniors especially challenging for healthcare providers?
Absolutely. One of the things, and I do think it is the main thing, is this internalized stigma that older adults don't suffer from addiction. But beyond that, when older adults have addiction, first of all, they are more likely, research tells us they're more likely to have at least 2 other chronic medical conditions. And very often practitioners, and think about our healthcare system, it's not like you're going to sit down with a physician or a nurse practitioner or a PA for a half an hour and it's go, and they're going to triage and focus on the most important thing. Now, what oftentimes they miss is that the most important thing, if they've got COPD, the person's going to look at smoking. But if they have more bone breaks and falls, the likelihood that a practitioner is going to look immediately at substances, the influence of substances, it's less likely. They're going to go to their training that says, let's look at the neurological reasons and such. And so a lot of the symptoms of addiction that would be very clear that any doctor, if I walked in and I'm having falls all the time, and they're going to look at me askew if I'm having memory problems, they're going to ask right away. They're going to ask about my substance use right away. Things are in older adults, practitioners in their training have been generally trained not to look for substance-related causes, but for other related causes associated with aging. And so a big push that we have is, and I love to get in front of physicians and nurse practitioners. And by the way, they love it. People think doctors don't want to hear anything and practitioners don't want it. That's not true. If you can put real information in front of them that says, hey, if you add these questions to your screening, you might catch some things. They want that. So I think that's the 2 biggest things. One is that it is that stigma. But the other thing is that a lot of the symptoms of alcohol use disorder and other substance use disorders can mimic issues that are common with aging in general. And that tends to be where practitioners look first.
I want my listeners to know that with alcohol abuse, there is a dementia that can develop, and that dementia can be reversible if it's caught early. So you don't, and I can tell you, my concern is for the family caregivers out there that see their family member abusing alcohol or other drugs, and or the little anxiety-ridden grandma that has to keep popping her benzodiazepines to keep her calm. A lot of these people, now the ones that get on the benzodiazepines actually have to go to the doctor. But a lot of people with alcoholism don't even go to the doctor. And I see so many family caregivers dealing with that, trying to get that person to a doctor. And I find that many respond in crisis because a fall occurs. And that's when it's finally addressed that, we have a drinking problem. The other issue I'm also going to address is not just a lot of the family caregivers are older and they're coping with providing care. So they're both drinking, or the caregiver's drinking or popping drugs because, again, Stress is very real. 63% of family caregivers become seriously ill or die before the person they're caring for does because of the chronic stress. And a lot of them think that a beer or a cocktail and then drinks afterwards or after their loved one goes to bed is acceptable, but they don't understand that, again, it's not coping with the situation at hand.
Those are important reminders. Is it 63%?
Yes, it is.
I did not realize that.
And I will tell you, it was 25 years ago, I started my first website. It was called aginghomehealthcare.com. And then it was 50%. And now with all the Medicare changes right now, we are in a public health crisis. The family caregiver is the single largest pillar of the long-term care industry. And they provide $650 billion of unpaid care a year. And there's no respite care. There's nothing for them. Now, with all the changes we've had with Medicare lowering reimbursement for rehab and stuff, we are expecting our family caregivers to provide care at a level that was once provided by healthcare professionals. And we are in deep doo-doo here in this country because it's very unsafe now. I'm seeing unsafe discharges to home like I've never seen before. And the other thing we're seeing is social isolation. We are seeing the highest level of suicides in the elderly because of this. And a lot of it is overdose because they can't cope.
You're deep doo-doo. I think as an epidemiologist, I put on my epidemiology hat. I think deep doo-doo needs to be like that you're absolutely right. That's where we're at. But it's extraordinary. And talk about another silent epidemic. Think about caregivers. Even when I worked with children, here in Palm Beach County, this is many years ago, about 25 years ago, and I'm working with a very high-risk population. And I started working with people who the grandchildren were being raised by the grandparents because parents were either abusive or on the street this is again like 25 years ago. And in Palm Beach County, there were roughly 6,000 families that were caring like that. And I thought the burden's incredible. And now when you talk about families who are supporting, and a lot of these families are supporting both their aging parents and their own they might be young grandparents, or they still have adult kids that are close to home. Yeah, it's an amazing thing, and nobody's talking about it. So thank God you are.
Yeah, I actually, when I was growing up, my next door neighbors, the grandparents were raising the two grandchildren because the mother had a severe alcohol problem that she could never overcome. And then of course I'm an adult child of an alcoholic. So I've been around the negative impact drugs can have on you. Can you share some effective treatment approaches that are adapted specifically for older adults, John?
Absolutely. So first of all, what you'll find is that there's very little research about older adult treatment in a residential setting because there are now more programs that do this, but there hasn't been. Prior to that, what you'll find is any research on older adult treatment, it comes from outpatient programs. And what they found, number one, is that patients in older adult specific programs better outcomes when they're in a peer group have better outcomes than when they are not in a peer group. And it's significant. So the first thing is simply having a peer group of other older adults who are struggling with the same thing. It is incredibly powerful in improving outcomes. It's important to remember that we talked briefly that older adults have different physical needs. And so any residential program, any program that is treating older adults must also have geriatric competent medical professionals that can also deal with the secondary or even with the other chronic illnesses. I was talking to the Florida Association doing a training at the Florida Association of Geriatricians, and I had this geriatrician come up to me afterwards and And she said, I get what you're saying, but man, I sent a patient to treatment. And yeah, he came back 2 months later and he needed it. It was alcohol and cocaine.
Yeah.
He was 76 years old. But his diabetes was all out of control, all these other things. So you have to be able to deal with those medical. From a cultural perspective, the number one, research tells us that the number one thing that is predictive of overall reporting a higher quality of life in older adulthood is having a sense of satisfaction with one's personal spirituality.
Yes.
Now, that does not have to mean religion, but if you're going to address older adults and addiction, you have to have a competency in addressing issues of spirituality. That's a whole nother weekend. I'll send you a link for a good talk on that.
That'd be great, because we can put it on our information, the show notes, and as well as on the page that we create, because people will be interested in that. You made a point that I think is really important, because I've been in many behavioral health units. I did agency nursing so that I could get experience in different arenas. And one of the things I learned, and this is insulting, and anybody who's a psych nurse can send me negative emails at how terrible I am. But psych nurses, I always tease, they're not real nurses. And that's offensive, I know. And I know, look at you like, oh my God, you can't say that. But they forget about the medical side of things. They're not thinking about the diabetes. They're not thinking about, I can't tell you how many times I've come to a unit. I would work on weekends, and from one weekend to the next, the treatment that I did on a wound or something would not have been touched, because we're a culture, even in medical, we don't do a holistic approach to anything anymore. Everything's very specific. And what I loved about what you said, and what really hits home for me, is that you're absolutely looking at the whole person. You're considering their illness, not just their addiction, but the physical conditions that need attention. Because as soon as somebody gets sick and I'm not talking addiction right now, but on a psych unit, a behavioral health unit, they go off the unit. And it's really, why would you can take care of it here? But the nurses, that's not what they want to deal with. And on the other hand, the nurses on the units don't know how to handle behavioral issues. So it's really hard, and there's got to be. So I see that's something that your program offers that is rare. And that is so important.
I think I'm the luckiest guy. We're the luckiest because we're on a 14.5-acre campus. And so all of our programs, though there are different buildings and such, it's one campus. And our nurse practitioners and our medical professionals and nursing professionals are a team that are just, I don't know if anybody, this is just audio, but they are linked, right? So they're right next to each other physically. And so because you're right, there has to be that interdisciplinary work. And then the therapists, right? The therapists, we have a multidisciplinary team meeting every morning here, where you get physicians and nurses and nurse practitioners. You get the psychiatric, you get the psychotherapists. We also get our paraprofessionals who are on the units. We call them recovery advocates, the techs or whatever, and who are with the patients more than anybody else and are constantly working as a team. In healthcare, you're absolutely right. We have failed to work as a team. And one of the things I'm so lucky is I get to be in this place where that's exactly what we do. It's a team, because you need a whole team for a whole person.
It takes a village.
Yeah.
I love that. And you know what I have to say? That's a rarity. I don't see that in healthcare. And in fact, just off topic right now, I'm going crazy because in the hospitals or in the rehabs, if a person refuses anything, turning or whatever, they're saying they have the right. So they're developing bed sores, pressure sores, and sores on their heels. And I'm like, when does it stop being their right to you're causing them harm? And but it's a thing right now that I'm seeing people come home that have pressure sores that were never even documented because they never checked their skin. And I'm like, what is going on in the world? And then when they look at us old nurses, like, oh, you're brutal. You don't know what you're talking about. And I'm like, come on, take me on. And it's just sad because we've really, our healthcare, quality of healthcare has declined rapidly. And like you said, we don't have, the doctors right now only get reimbursed for a 15-minute visit for a patient. And one of the 15 minutes, they're to see the patient, diagnose them, assess them, diagnose them, treat, and then document everything. And so many things get missed, so many.
It is astounding to me that we as a nation, if that standard was applied to auto mechanics, we would never stand for it. We would say, I can only have this guy, I've got a problem with my car and he can only look at it for 15 minutes and then he's just got to duct tape or do something because I got to go. We would never stand for it. And yet that's what we have with the most important physical asset that any of us have, our physical body. And so until we get I agree with you, a mindset change that says we have to do something different.
I will tell you, I recently, because I was curious, I took an insurance course, not to sell insurance, but to learn what they offer and how they offer it. And what astonished me the most was our government policymakers have created these high co-pays, high deductibles to deter the use of benefits. And our mental health system is so broken and they don't want to pay for anything. And it's really sad. So what we have is a time in our health history, medical delivery system, where we actually have people that need care, but unless they can privately pay for it, it's not offered to them.
That's right.
So we have done nothing changed. The poor will always be delayed, denied. And the VA says, delay, deny, and wait to die. And that's what our healthcare systems become. John, what practical steps should a caregiver take if they suspect a loved one is misusing substances?
The first thing is to make sure that if you are concerned that a loved one may have a problem with substances, you have a medical issue. And so often people will think that because it's substance related, that it's something that they should figure out on their own. It is not. First and foremost, seek professional help. And what kind of professional is that? That is if there are specially trained medical and clinical professionals. So if you're looking for a physician who is an addictionologist, you're looking for someone who has, after their MD or DO, they have credentials like ABAM, American Board of Addiction Medicine, or ASAM, American Society of Addiction Medicine, with nurses, right? You'll see there are credentials. I just zoned the addictions credit, but there is an addiction specialty within nursing, within medicine. So know this, and the same thing with psychotherapists and psychologists. These are all people who can help. But what you need to know is that not everybody is trained to understand addiction just because they understand medicine or nursing or anything else. And so seek help from professionals who have credentials and training in addiction specifically, and they can help you figure out if it's a problem or if it's not, or send you in a different direction. You can always reach out to Hanley at hanleycenter.org. We have a lot of information on our website. You could call our admissions if you have questions, and they'll help you, even if you never come into treatment, they'll help you find help in your area. But the most important thing is to remember when you seek out, you do not have to do this on your own. You shouldn't have to figure it out on your own. It is a healthcare issue, so get healthcare help and make sure that person that you're getting help from, or make sure that they have training specifically in addiction. Any therapists, physicians, nurses, nurse practitioners, PA, do not have training in addiction, so make sure you're talking to someone that has that training.
Yes. Now, from your perspective, John, what gives you the most hope for addressing this epidemic moving forward? We have a silver tsunami coming. It's here and it's getting worse. The baby boomers, the oldest of the baby boomers turn 80 very soon, and the youngest are soon to hit 65 and retire. So what hope do we have that this is going to get addressed?
You're a huge part of it. You are a huge part of my hope. You and others who are doing this has been something that has been silent for so long. And it is still not, we're not talking about nearly enough, but more and more people are talking about it. More and more people are speaking out. And so I would say to anybody who is a professional or has any experience, writing about this, talking about this, doing research on this is so important for those who have lived experience. And why I say you, not to just suck up to you, which is lovely, but it's because you have both that professional and you have that personal story and that personal experience. And my hope is in talking and training. That's where my hope is, because when we talk about physicians, overprescribing, and I have yet to meet a physician or a medical professional who did not want to do good for their patients.
Oh, absolutely. And they're unable to. Yes.
The more knowledge, the more information, the more stories we have about this. So my biggest area of hope when it comes to this, it is people telling their stories, and both professionals and people with personal experience getting out there and talking about this and making this as public an issue as we possibly can.
How do people find you, John?
Easiest thing is to go to that website, Hanley Center, HANLEY center.org, or hanleyfoundation.org. And you can look at, about us, and I'll be in there, and you can email me. There is a lot of great information. I want to tell you, if I 3 seconds off topic, but just because of what you were talking about, Hanley Foundation has partnered with the National Association of Children Impacted by Addiction. And we also have a 3-day program for children ages 7 to 12. And there's a ton of information on there, and it is absolutely free. You don't have to be associated with Hanley Center. You don't have to be if you know a child ages 7 to 12 who's been impacted by addiction, go to hanleyfoundation.org, look up that site, and get information about it, because it is something that, Diane, I'll tell you, so many people, including myself, say, oh my gosh, had this been there for me,
absolutely,
it would have changed my life.
Absolutely. Because they're forgotten children.
Yes.
And I know from my personal experience, my mom died young. You become very old very fast.
Yes.
And for me, it was like I always felt like the weight of the world was on my shoulders. Now, my dad was a functional alcoholic. He worked and stuff, but and people don't understand that. Oh, your dad, he worked 2 and 3 jobs. He still worked, but when he drank, and he was a letter carrier, and in those days, John, people would have them come in and give him booze off the route. It walked around. In Pittsburgh, he was up and down hills. My dad was in really good shape. Or the guys, when they would get done, they would finish at noon, but they couldn't go back to the office legitimately till 3. They would all go meet at a bar and sit and drink all the rest of the afternoon. So it's just, oh Lord. But I love the program for children, because there are grandchildren out there that, especially with today's culture, with the family caregiver taking care of so many, the parent that's drinking, or they may even be drinking, and then they have these young children or grandchildren. It's just overwhelming for everybody. So,
well, I'll send you also the link to that. I'll send you a few things, because I know that you
and I'll put it on the page that we create. Great. John, thank you again for your time.
Thank you. This has been a great time. Thank you so much.
I enjoyed this so much. To my family caregivers out there, you are the most important part of the caregiving equation. Without you, it all falls apart. So please learn to be gentle with yourself. Practice self-care every day, because you are worth it.